Oh, thank you very much. Thanks, Dr. Maya, and thank you, Dr. Schivink, for the invitation. So I'll be talking about foraminal vein embolization for treatment of CSF venous fistulas. I think it's a nice, segue from the work of Tim, Mark, and Wouter. So just off-label indication, onyx for paraspinal vein embolization is currently off-label. Only on-label use for onyx is arteriovenous malformation embolization. These are my disclosures. This is the team here at Mayo, and without this, none of this would have been possible without this great team that we have. And actually, I want to give a special shout out to Dr. Peepgrass in neurosurgery, as well as Dr. Farb from Toronto Western Hospital and interventional neuroradiology for getting me interested in spinal CSF hypotension. So just a quick thing, at our center, we use digital subtraction myelography primarily to diagnose CSF venous fistulas. We've had a lot of success with it. Patients that come here generally get day 1 on the right side, day 2 on the left side. And then if we find a fistula, we treat it either on day 2 or on day 3. So we kind of follow maybe more of the Cedars-Sinai model. Here's just, I know people have probably shown these things, but here's just like a nice picture of a CSF venous fistula in action on a digital subtraction myelogram. You can see here how that contrast is going out of the nerve root sleeve, into the foraminal vein and then into the azygous venous system. That's a nice unsubtracted view. And then I'll just show you a nice one here on the subtracted view as well. And this is a patient that we'll be following throughout the talk a little bit. So that's kind of why I just wanted to show that to you. But here again, you can see that nice example of a CSF venous fistula with all the venous complexes that are being opacified. So I know many of you have probably heard this before, but where did this idea of this transvenous embolization come from? As Marcel knows, transvenous embolization of brain AVMs and dural fistulas and other types of arteriovenous lesions is very en vogue right now in neuroendovascular. And we had this one patient that I actually did this DSM on, and we saw this right T2 CSF venous fistula. You can see how complex all the veins in that neural foramen are, and then how it's then going on to pacify this much larger vein, the superior intercostal vein, and then the azygous vein. And this case, which occurred, during kind of the COVID shutdown in early 2020, got me thinking about, is there a way to just get into these veins and block them off with glue from an endovascular point? And then, I started doing some digging and came across this great book by Professor Theron, who's actually, still working over in Spain, I believe, and Professor Moret, who's still working at the Bicêtre Hospital in Paris on spinal phlebography. And it's very interesting because in one of these things on the back of the book, it says this technique is in use today in almost every university clinic in France. And that was back in the 1970s, where spinal phlebography was being used to diagnose mass effect in the lumbar and cervical spine. And in this book, you see these beautiful epidural venograms demonstrating kind of the ventral epidural space, the foraminal veins, and then kind of the ascending lumbar veins bilaterally. And this got me thinking, well, maybe there's a route, maybe it is going to be feasible to get into these veins and find a way into the foramen where the CSF venous fistula is and then block it off with glue. And thankfully, I didn't have to be that creative because within the book, there were all the roadmaps and kind of catheter shapes that would be ideal into getting some of these veins. And this is mostly focused on lumbar and cervical, but I thought about it and I thought, it can't be that difficult to get into the azygous vein for the thoracic, which is where most of these CSF venous fistulas occur. So the idea here, for that first patient that we had that was like kind of a right thoracic would be to basically, have your patient that has this, CSF venous fistula, and then basically try to find a way to advance a catheter up the IVC, into the SVC, then into the azygous vein, and then advance a little microcatheter into this paraspinal vein, and then shut down this whole vascular complex with glue or onyx. And, this just kind of shows some of the anatomy, but basically, we have our paraspinal vein. That's one of our embolization targets. The veins in the foramen, the foraminal veins, and then also get those epidural veins, because, the goal here is to occlude any route of egress of the CSF venous fistula. So, for most of these lesions, we're talking about things in the thoracic spine. Just as an aside, about 80% of the patients that we've treated have been done under conscious sedation or minimal sedation. The patients that we treat under general anesthesia, it's generally, patients that, are uncomfortable, like they got general anesthesia for the DSM, we're a quaternary referral center. So by the time people have gotten to us, they've been poked and prodded, so much, and they just don't want to be awake for these, procedures anymore. But 80% are under sedation. But basically the steps are catheterizing the azygous vein. So this is, the inferior vena cava. This is, the superior vena cava, and this here is the azygous vein. Then we do the azygous vein venogram, where you can clearly see all the little, kind of intercostal vein or paraspinal vein origins. And then do a paraspinal vein venogram. That's what it looks like on the AP. There's the lateral, and then onyx it. And then I'll go over the anatomy in a moment. Yeah, so what is the anatomy? So this is our typical patient, a right-sided thoracic fistula. Okay, so this is the AP view or the frontal view, and this is the lateral view. So in blue right here, we have the azygous vein. So this is the azygous vein, which is, a vein that primarily functions to drain, the paraspinal venous system. The green on the AP, this is the paraspinal vein. And here on the lateral, you can see this paraspinal vein. So these are the veins that are running along the side of the vertebral body. The purple is the foraminal veins. So these are the veins within the foramina. And actually, you can see the outline of that venous plexus, and this is where the nerve root is coming out. So the nerve root is surrounded circumferentially by these veins, and you can see how kind of complex that network is. There's so much redundancy in that network, which is one of the reasons I like to use the onyx, because the onyx is very good at finding all the redundancies. And then the white is the epidural or the ventrolateral epidural veins. So typically, when we're embolizing these things, my preference is to get some in the epidural, a lot in the foramen, some in the paraspinal, and then there is an intercostal vein that goes out laterally. So I like to have a little bit intercostally as well. So here's our patient. Again, I showed that DSM on this patient. You see, this view here of the venous complex getting opacified. Here it is another way. Here's that venous complex getting opacified. And then here's the venogram from that patient. So you can see here, this is the veins right here. And then here we go, the foraminal vein, the paraspinal vein, and all that complex right here. So the venogram looks a lot like the DSM. And this is the onyx cast, showing that we've gotten, we've achieved the full embolization. So, again, lots of complexity to the anatomy. I know Peter showed a lot of the beautiful anatomical illustrations. I mean, there's just a lot of redundancy here. It's not this simple. There's so many different connections. Everything in the venous side is connected there's multiple ways to get anywhere in the venous system because there's just a lot of redundancy in the venous system because it is this low pressure system that, needs to have a lot of redundancy in order to function properly in the human being, right? And then here's just like a nice onyx cast showing how we get all that redundancy basically anywhere where a CSF venous fistula could be filling is blocked off with the onyx glue. Here's a nice picture on the lateral. Here, I'm going to show you one more thing, and then I'll go into some of our results. So here's just like a little video showing the procedures. So, this is, typically these are 20-minute, 20 to 30-minute procedures. We're getting a wire in the azygous vein. Then we're advancing a, diagnostic catheter deep into the azygous vein. That gives you like a little bit of stability. And then once we're inside the azygous vein, we proceed with doing the azygous vein venogram. And that kind of just gives us our roadmap and shows us what the venous system looks like. And it's actually so interesting, having done a lot of these now, like over 70, maybe close to 80 patients. And there is a lot of variation in the azygous and hemiazygous venous system, but typically this is what it looks like. So once we're in there, we take what's called a microcatheter and actually get into the paraspinal veins. And one of the reasons I do like, this technique is that I always know that I'm in the vein because I've accessed the vein, I'm not as concerned about, stuff getting into arteries or intrathecal or anything like that. But that's just me because I do neuroendovascular procedures and, that's the world that I know, right? So once I have my microcatheter inside the vein, here I have my microcatheter inside the paraspinal vein. And this is something I just want to point out. When the wire goes medial, then you're at the spot. So this is like the pedicle right here. The wire going medial means that the microcatheter is basically in the foraminal vein. So now I have my microcatheter here. My wire is going medial, so I know that I'm pretty much where I want to be. And then once I'm there, I do a venogram. So here's our microcatheter. You can see it's positioned very nicely at the level of the foramen. Here you can see in the lateral, right next to the foramen, okay? And once I have my microcatheter in position, I do the venogram to prove that I'm exactly where I want to be. I'm in the vein, I'm not extradural. And then after that, we proceed with the onyx embolization, generally under, flow arrest with the balloon. But the onyx is this black tarry stuff. And Mark is right, it does create, artifact and issues on postoperative imaging. But typically, if you get a cast like this, you're not going to see, these veins are permanently occluded. And I just want, this is intended to show just how many veins are in that area. And, when you do a DSM or a CTM, you can see how complex some of these fistulas are. And just one of the things, that I do like about liquid embolic agents in general is that they do find pretty much every nook and cranny, all the different venous outlets that could potentially be used for a CSF venous fistula. You can see we have some epidural here as well, which is something that I like to see in the final result. So our first case series, we published in November. Our second one is we're going to be submitting it, hopefully this week. I'm sorry, Jeremy, if you're on the line, it's my fault that everything's delayed. But our first 5 patients, all had brain sag and headaches, standard. A few had cognitive problems, tinnitus, hearing problems. I won't, bore you with this, but this was patient 1. Thank you to patient 1. This was our first embolization. We were pretty, cautious. Now I like to see a lot more because now I understand that CSF venous fistulas can be very complex, and this is not the ideal onyx cast, but thankfully patient 1 got better and is headache free over 1 year out from embolization. Here's patient 2. This was much more aggressive of an embolization. You can see how all the brain sag findings resolved. Patient 3, larger fistula, more of a simple I guess angioarchitecture is the term that I like to use. This is the only one I did transjugular. I'll never do that again. It was the big pain, made everything more difficult than it had to be. But that one turned out good. Patient 4, similar story. And then patient 5 who had bilateral fistulas, we closed both of those, and you can see resolution of the pachymeningeal enhancement. Our series to date, so this is looking at patients who've had DSM done at Mayo with a definite CSF-venous fistula that was determined by the neuroradiologist performing the DSM. So these are definitive, not some of the questionable ones. And we have treated several patients with questionable fistulas, with this technique. All but one patient was discharged the day of the procedure. One patient just had some nausea and vomiting, probably related combination of rebound hypertension and the effects of sedation medicine. We've had about 10% require medical therapy for the rebound hypertension. We have had one patient who actually got a second leak and got a leak at another level. We've had a couple complications, paraspinal vein perforation in a couple cases, which, if you think about it, when you're doing a blood patch, undoubtedly you're perforating the paraspinal vein, and there are no clinical consequences from these. And, similar to when you do vertebroplasty, we've had a few patients where you can see little ditzels of onyx in the lung, but when you do a vertebroplasty, for example, for those of you in the audience who do those, I think up to 30 or 40% actually have little ditzels of cement in the lung. Generally, it's inconsequential. We've started getting HIT-6 scores on all of our patients pre and post. I know it's not an ideal headache score for CSF hypotension related headaches, but it is a good one, I think. And we've had significant reductions in HIT-6 scores from around 70 to closer to 40. And then the perceived or patient global impression of change scores have been very good. About 85% are very much to much improved. We've had one patient minimally worse secondary to rebound hypertension. So that's that. And then it's always good to see improvement in imaging, especially if you're a radiologist. But the Burn SIH score pre and post, we've had pretty remarkable improvements in those as well. And I will say that probably you have at least half a dozen patients now that did not have any brain sag, but definitely had CSF-venous fistulas that have been treated, and those patients did not have any improvement in their burn scores because their burn scores were 0 pre and 0 post. There's a lot of little technical nuances for this, right? I mean, the anatomy in the cervical and lumbar spine is pretty easy to navigate compared to that in the thoracic spine, which is good because, I think that, this is a great technique, especially for patients with, appendicular nerve roots in the cervical or lumbar spine where, you can't be as aggressive surgically in the foramina. So this is something that I've evolved on. T1 to T4 used to be like my least favorite because there's this superior intercostal vein, but I've figured out an easier way to do it that makes it actually pretty straightforward, and I'll show one clip of that. And then there's choices of your liquid embolic agent as well. So I don't know if this video will work here, but for some of these left-sided upper thoracic ones, I've actually been starting to go in the vertebral vein, which is very easy to get into. It runs right next to the jugular vein. And then from there, you can opacify the epidural venous plexus. And the epidural venous plexus, the lateral epidural venous plexus, is actually very capacious, specifically in the cervical spine. And it's actually very easy to get little microcatheters into that epidural venous plexus. And you can actually navigate, once you get on, the upper cervical epidural venous plexus, like on the left side, for example, you can actually get anywhere on the left side, with the microcatheter. And it's fairly easy to just to navigate a wire into any of these upper thoracic level fistulas. And that's kind of what I've been doing for these lately. It just makes it a lot easier than some of these other techniques that I was doing earlier on. Obviously, this is all evolving, but you can see here we were able to navigate into a left T2 fistula fairly easily. So future directions, Mark's data are so convincing, and his approach is just so elegant, and I think it's time to consider RCTs versus blood patching and surgery, and I think just like in other areas of minimally invasive therapy, everything's going to have a role, and some endovascular might have a role for some cases where blood patching may struggle, or some fistulas where blood patching may struggle, and same with against surgery. There's newer liquid embolic agents coming out that use the same copolymer that Onyx uses, but they're less radiopaque, so they're not going to create as many artifactual issues. I will say that you can see through Onyx on a DSM. Glue is a very cheap liquid embolic agent that can be used. And I've done a couple patients with that now, and the results are pretty good. And then obviously clinical registries. And I will say that, a lot of centers across the US in Europe have already treated at least one patient. And there's a lot of excitement regarding this approach among neurointerventionalists, of course. Again, I want to thank everybody on my team, and always happy to answer questions. Thank you very much.